You said the reattachment of the urethra was the final stage, but I thought in laparoscopic surgery the urethra is not severed. Well, that's not true. Urethra is severed. Laparoscopic just means you go through the abdomen slightly differently instead of making an incision. For radical prostatectomy for cancer, you have to take out the whole prostate, which means that the bladder, the urethra, the prostate, in between the prostate has to be taken out, and you join it, whether we make an incision in the middle of the abdomen, the lower part of the abdomen, or through the laparoscope. In fact, robotics is laparoscopic, except that it's just a much fancier way than so-called laparoscopic without the robot. Some of you may have had laparoscopic gallbladder surgery, for example. They didn't have the benefits of a robot, meaning that the surgeon would stand there with the instruments inside and looking at a TV screen, a monitor, and working like this, as opposed to what I showed you, which is, as I say, I'm in the console, the instruments are then all wired up, the camera is fancier. But anyway, that's, I hope that answers your question, but I think your idea of laparoscopic is slightly different than what actually happens, because we do have to, unless you're thinking of one of the minimally invasive procedures, but if you're taking out the whole prostate, that takes it out. So what are the benefits of the Da Vinci system was another question. So that's the robotic surgery, robotic prostatectomy. That's really a big debate still, and that's what I tried to mention here was, the quote was, does the early bird get the worm, or is he a fool? Or, is it Judgment Day, or is it, and so forth. So what are the advantages? Well, there are clear advantages, one being that it's slightly shorter length of stay in hospital, on average. There is slightly less blood loss overall, in terms of there is slightly lower risk of needing blood transfusion. Now, we're only talking about 1 in 100 for people having open removal, 1 in 100. And then we cut that down. We're doing with a robot. It's not so much the actual procedure, but the system is that you're putting the instruments in and you're blowing up the abdomen with carbon dioxide. So the abdomen is kind of tense, so that you have the space to work inside. That actually is so-called what we call pneumoperitoneum, the inside of the abdomen. That actually compresses some of the blood vessels during the procedure. So that little bit of oozing, that it all adds up, bits of bleeding here and there, that adds up. And that doesn't happen with the open surgery, because whereas inside the abdomen, that cuts down on that bleeding. So on average, it's like instead of say 400 or 500 cc's of blood loss on average, sometimes you go to 1,000 or 1,500 cc's for the open procedure, in which case the occasional person needs a blood transfusion. If you do it with a robot, the average blood loss is less than 100, 150, 200 cc's, and very, very few people need transfusions. So that's one of the advantages. Another, I suppose, your main reason for asking is it better for incontinence? Is it better for preserving nerves, for erections? The answer is maybe, but it really depends on, it's not the system. You can have a total novice who does not know the system very well, who doesn't recognize much, and he sits on the console. He can cause a lot of damage, okay? As opposed to someone who's done, an expert who's done 3,000, 5,000 prostatectomies, whether he does it open or with a robot, whichever technique, is really the surgeon who has to recognize the tissues, recognize the anatomy, does it with the right techniques and with the right indications. Where should I spare this and where should I not spare? Is it safe to leave that bit of tissue behind, or am I going to leave cancer behind? It's really all those decisions. It really is not whether the machine itself is better. But overall, yes, using the machine, there are some slight advantages. There are some slight disadvantages as well. As mentioned, the cost of the machine and so forth, the upkeep and so forth. It takes longer to do a robotic procedure than an open procedure. Okay, I don't want to monopolize that because there are a few other questions. Oh, quite a few more, so okay. Okay. This one's easy. What's the primary function of the prostate? The prostate makes some fluid. It makes some enzymes. It's rich in zinc and rich in some other materials. It basically secretes this fluid. When a man ejaculates, that's some of the fluid comes from the prostate, some of the fluid comes from the seminal vesicles, and that fluid gets mixed in with semen, with the sperms, which together is what you notice as semen. The majority of that, actually 49–50%, comes from the prostate, 49–50% comes from the seminal vesicles, and then 1% comes from the testicles, where the sperms come in. Okay, so the sperms, so the primary function is for the sperms to swim around and have nutrients. So the answer to your question is actually to help with reproduction, having a child. The sperms then get transported to the female. All right. I come from the UK. There's talk about some stem cells giving a lot of hope for curing or eliminating cancer. Yes, there's a lot of thought. There's work being worked on prostate, but that's too big a topic really to cover. I guess in terms of curing, I mean, at the moment, yes, there are a lot of labs working on stem cells, different uses. There's a lot of hope, a lot of promise. Right now, it's not really. I mean, it's certainly not there yet, even for clinical studies. This one, okay, very quickly, is BPH a risk factor for prostate cancer? The answer is no. Okay, so that answers that. A person could have benign prostate enlargement without cancer, without risk for prostate. Even a very big prostate is not it's not a risk factor. This other person, you know who you are. I won't state your age. It says radical prostatectomy post-op 3 months, PSA currently 0.04. Now, is that actually 0.04? Is it? If it's an actual detectable number, then I guess you realize that the PSA should theoretically be less than such and such, less than 0.01 or whatever. If that's actually is the number, I mean, just having that information, I can't tell you what the options are. It really depends on what the trend is. Was it 0.03 3 months ago? Is it going to be 0.08 next month? Or has it been stable? What was the pathology? It depends on what the pathology, whether the so-called margins, you need to get from your surgeon whether the margins were clear, meaning it has the cancer on the pathology, whether it had actually gone to the margins, had it reached the margins or not. What was the PSA, what was the Gleason score? Those are all factors. But in terms of actual treatment, right this very moment, probably, I mean, don't quote me on this, but if I just look at that, I wouldn't be recommending any treatment right this moment. You can't really do it on just one data point, but you have to be, in the context of the individual, in context of the whole, the pathology and the other findings. So your physician should have a discussion with that on that. This is a very good question. Can radiation therapy, 30-35 treatments, cause leukemia later in life? There is certainly a lot of thought. Now, whether that particular treatment caused in one individual is hard to say, but yes, there's a whole field, so-called secondary malignancies, meaning cancer that is developed from previous radiation treatments and previous chemotherapy treatments for various things. So in particular, we're talking about prostate. So prostate cancer, yes. Whether it causes leukemia, I can't say for sure. I'm not a leukemia expert, but yes, it's possible. What we do see as a urologist, I certainly see, and all my colleagues see, that is people getting bladder cancer. Some people get, because it makes sense, the bladder is right where the radiation, or close to where the bladder, where the radiation was aimed at. So we actually see bladder cancer sometimes, not in everybody, of course, but in a certain percentage, higher than general population who did not have radiation, for example. And as you know, radiation is radiation. You hear, from way back, a lot of you are old enough, Hiroshima, Nagasaki, atomic bomb, there was radiation, right? People died then, but there are lots of people later on developed cancer, and there's concern about thyroid cancer and some of the new exposures to nuclear accidents and so forth, thyroid cancers, and that's radiation. So this is a more controlled form of radiation, but yes, it still can cause potentially can cause cancer, but you have to weigh the pros and cons and the side effects. Not that I'm saying people shouldn't have radiation, right? So, but that is something we don't want to give too much. We don't want to give unnecessary radiation. Of course, that's why there's all the discussion is whether in terms of risks and benefits. If there are a couple of questions sort of together basically on active surveillance. If one is diagnosed with prostate cancer and you do nothing, what are the consequences? Well, it's a broad question. You can't really answer that until you actually know the exact details of the diagnosis in your particular person. Key is how much prostate cancer was seen on the biopsy. What was it Gleason 6? Was it Gleason 7? Gleason 8 or 9, 10? What was the PSA? How did it feel on rectal exam? If the so-called insignificant cancers, meaning very small cancers, and Gleason 6, yes, there's a lot of data. There is a lot of data now that shows that we can safely watch those people. But if it's a higher grade or higher risks, even cancer, what would be the consequence if it's untreated? Well, it will grow. It can grow to be bigger, and it will cause blockage of the urethra, some bleeding possibly, but then it can spread. Or the blockage, you can block and back up. The kidneys won't drain as well. The urethra, where the urine function can void as well, but then it can spread. It spreads to lymph nodes. It spreads to other places, notably the bones, to other organs, and then so-called metastatic disease. So prostate cancer is really a very wide spectrum of disease. Some consider the low-risk Gleason 6 as not even cancer anymore, something that we can safely watch. So that leads to the other question. A very perceptive individual says, if your treatment, my treatment, was being done on PSA less than 10, Gleason less than 7, are these not candidates for active surveillance? And says, yes, that's exactly the point, actually. These are those individuals, but they knowingly want to have something done. They are not comfortable with active surveillance. So this is a purely choice on informed choice on their part that they would rather do something. They can't stand the thought of having something in there, rightly or wrongly. There is cancer. They think they've got cancer and it's not being treated. So the ethics approval for example, my study was that based on that is this procedure right now is still considered a safety study, just as so-called feasibility or safety study to test. It would purposely didn't treat the higher risk cancers yet because we still don't know for sure how well this technology works. And that's the same for some of the other technologies as well. So that's why we wanted to not disadvantage those individuals by testing them with this technology, not knowing what for sure whether it'll work or not. In animals and other, we know that it kills the cancer. Whether that needs to be killed or not, that's a good question. But yes, you're right. This is the group, but these are individuals who opt for something done, and that's where this may come eventually as focal therapy as well. To just treat the area that they think needs to be treated. Rightly or wrongly, that's how some people are approaching cancer.